Choosing Wisely Canada is a national campaign aimed at reducing unnecessary tests and treatments in healthcare. In this video, we present one of the top 5 dermatology recommendations for physicians and patients, which are set by the Canadian Dermatology Association and Choosing Wisely Canada. Don't routinely prescribe antibiotics for bilateral lower leg redness and swelling. Let's start with a case. You are a third-year medical student on your internal medicine rotation. You were assigned a patient, Mr. Lee, who is a 68-year-old man who initially presented with acute onset of redness of his lower legs 24 hours ago. He was diagnosed with cellulitis, admitted to the hospital, and immediately started on IV antibiotics. Mr. Lee stated that the pressure and tight sensation in his legs began 5 days ago. He also complained of increasing pain and sensitivity to touch prior to coming to the ER. He has a long-standing history of congestive heart failure and takes furosemide 40 mg PO daily. On examination, you can appreciate diffuse indurated erythema of both of his lower legs. The legs are also very warm to touch and fairly tender upon palpation. You notice no clinical improvement since starting the IV antibiotics 24 hours ago. You begin to wonder if cellulitis is the right diagnosis. Cellulitis is a common skin and soft tissue infection, most commonly caused by beta hemolytic streptococci and Staph aureus. It often presents as unilateral lower leg redness and swelling, with 70 to 80% of cases involving the lower extremity. It's important to be aware that in darker skin, cellulitis can present as violaceous rather than erythematous and can be hard to appreciate. It may be helpful to compare the lesion with the surrounding skin. As well, the skin can feel warm and tender. Cellulitis can have a spectrum of presentations, and many other conditions can have similar clinical features called pseudocellulitis. Differentiating between cellulitis and pseudocellulitis can be challenging at times. Around 30% of cases of cellulitis are misdiagnosed, and this outlines the importance of distinguishing cellulitis and pseudocellulitis to avoid unnecessary hospitalization and unnecessary empiric antibiotic treatment with potential significant adverse reactions. The ALT-70 is an objective decision-making tool designed to differentiate cellulitis from pseudocellulitis. You can download the MD Calc app for quick and easy access to the ALT-70 tool. It is validated for use at the time of presentation for a patient suspected with lower extremity cellulitis in an emergency room setting. It is a simple scoring system which tallies points for asymmetry, leukocytosis, tachycardia, and age above 70 years old. A score of 3 to 4 indicates uncertainty and highlights the importance of considering alternative etiology. A score of 0 to 2 suggests patients are unlikely to have true cellulitis and they have a likelihood of having pseudocellulitis of above 83.3%. As you can see, unilateral involvement has the highest weight in the calculation. This really emphasizes how rare it is for cellulitis to present bilaterally. It is important to note that the ALT-70 has not been validated in patients who are already treated with antibiotics, with patients with recent history of trauma, burns, diabetic ulcer, or known hardware at the cellulitis site, or have a history of osteomyelitis. Therefore, the ALT-70 is not recommended for use in these cases. After applying the ALT-70 score and obtaining a score under 5, you should reconsider the differential diagnosis for pseudocellulitis. For bilateral lower leg erythema, the differential diagnosis includes stasis dermatitis, acute lipodermatosclerosis, irritant contact dermatitis and allergic contact dermatitis, and as well small vessel vasculitis. Stasis dermatitis usually occurs in patients who have poor leg circulation. Besides being erythematous, it typically presents with scaly and eczematous patches or plaques on chronically edematous legs. It is often pruritic, so you can look for signs of chronic scratching or rubbing indicated by lichenification of the skin. The most common and most severe site of involvement is the medial ankle. However, the skin changes may extend up from the foot to the knee. Patients will not present with systemic symptoms like fever and malaise. Past history of venous insufficiency, including varicosities, pitting edema, and hyperpigmentation, will lead you towards the diagnosis of stasis dermatitis. Having stasis dermatitis in turn can lead to increased risk of cellulitis and contact dermatitis due to the disruption in the skin barrier. Lipodermatosclerosis is caused by inflammation of subcutaneous fat leading to fibrosis and necrosis as a result of chronic venous insufficiency. It is a much deeper process, and therefore the skin will be indurated or hard. It can be classified into acute, subacute, and chronic stages. In the acute stage, it can present as a painful erythematous indurated plaque on the legs, which can mimic cellulitis. But lipodermatosclerosis progresses slowly over weeks to months and often presents bilaterally. Irritant and allergic contact dermatitis can mimic cellulitis, and it will be considered if the patient history indicates exposure to a relevant irritant or allergen on their lower limbs. In the acute stage, it presents as erythematous plaque, and you may even notice vesicles. The rash can be well demarcated, and you can look for sharp lines and angles for signs of outside job. Review all topical medications, creams, or products that the patient applied on the skin. Include their occupational and recreational exposures to find out the causes. Patients with ACD will complain of intense itch, and patients with ICD can complain of itch, but also burning and stinging of the skin. Infectious symptoms and signs will be absent. Small vessel vasculitis will present with multiple non-blanching and palpable purpura and/or petechiae on the shins, which are absent in cellulitis. It is important to keep in mind that the patient may have more than one diagnosis at a time. Detailed history and skin examination will help you delineate the underlying causes. Going back to the case, Mr. Lee, who was diagnosed with cellulitis, did not present with systemic symptoms of infection, had bilateral lower limb involvement, and did not respond to IV antibiotics. Looking at the rash again, you note that the skin change ends at the ankles. The skin color change is quite dull, rather than the bright red erythema you've seen before. There are features of peripheral vascular disease such as varicose veins and edema. All of these factors point to an alternative diagnosis. Since Mr. Lee was already started on empiric antibiotic therapy, you are unable to use the ALT70 tool to assess for cellulitis. This highlights the importance of doing a thorough workup and exploring the differential before a diagnosis of cellulitis is made. His clinical presentation of painful erythematous indurated plaques on the legs points you towards acute lipodermatosclerosis. The absence of systemic symptoms, absence of petechiae in purpura, as well as the lack of new occupational and recreational exposures help to redefine the differential. You confirm the diagnosis with your preceptor, and appropriate workup for peripheral venous insufficiency is initiated. Cellulitis is incorrectly applied as a diagnosis in 1 in 3 cases. It is crucial to understand the harm of overdiagnosing cellulitis. A Canadian study found that patients admitted for a diagnosis of cellulitis had an average length of stay of 7 days. A misdiagnosis of cellulitis can result in unnecessary hospital admission and prolonged or unnecessary exposure to antibiotics. Furthermore, unnecessary antibiotic treatment will contribute to antibiotic resistance. A failure to identify the correct diagnosis will lead to delayed treatment and poor patient outcome. From this video, we hope you understand the CWC's recommendation of don't routinely prescribe antibiotics for bilateral lower leg redness and swelling. These are the take-home messages of the video. 1. Cellulitis is seldom bilateral and presents with systemic symptoms. 2. ALT70 can help differentiate between cellulitis and pseudocellulitis. 3. Key questions to ask on history include presence of systemic infectious symptoms, pruritus, exposure to irritants, and history of venous insufficiency. Lastly, it is important to keep in mind that cellulitis can happen on the skin of existing pseudocellulitis.